Good morning, everyone. It is a great pleasure for me today to introduce Dr. Deepak Bhatt, who I have known for a long time and had the pleasure to work with in the past. Dr. Bhatt is a director of the Mount Sinai Heart Hospital and the Valentin Fuster Professor of Cardiovascular Medicine at Mount Sinai. He obtained his science degree from MIT, his MD from Cornell, followed by an MPH from Harvard and an executive MBA from Oxford. He trained in internal medicine at the University of Pennsylvania, and then he did his cardiology fellowship and interventional cardiology at Cleveland Clinic. That's when I met him. He completed his fellowship and then proceeded to stay as a member of the staff. Eventually, he moved as a chief of cardiology at the VA in Boston, and subsequently became the executive director of the interventional cardiovascular program at the Brighams, where he worked with the TIMI group and became the editor-in-chief of the Harvard Heart Letter. He became a full professor of medicine at Harvard in 2012, being selected by Brigham and Women's Hospital as a 2014 Eugene Braunwald Scholar. He received the Research Mentor Award at the Brighams in the Department of Medicine in 2016, and the ACC Distinguished Mentor Award in 2018. It's also the AHA Distinguished Scientist Award in 2019 and received the Society of Cardiac Angiography Interventions Master Designation in 2022. Deepak has authored over 2,000 publications and has been listed by the Web of Science as a highly cited researcher from 2014 to 2023. He was a principal investigator for many landmark interventional trials, including Charisma, Crescendo, Cogent, Reducit, Soloist, Sport, and Intrigue. It is a privilege for us to have you here, Deepak.
Well, thank you for that kind introduction. It's really a privilege to be able to speak to all of you this morning. And again, thank you not just for those kind words, but the many years of friendship. It really was a lot of fun we had back at Cleveland Clinic. A lot of good memories from those years. Well, it looks like mostly very young folks, I imagine, many people that are fellows in training. And what I was going to talk about today was acute coronary syndrome, starting from some of the basics, but then thinking not just about intervention, but also prevention of ACS. Before I get started with the specifics of my talk, these are some disclosures that pertain to drugs or devices I might or might not touch upon, and I will certainly talk about off-label uses of drugs and devices during the course of my talk. Let me start with the basics as far as acute coronary syndrome and the etiologies of acute coronary syndrome. In particular, plaque rupture accounts for the majority of ACS. Probably about 60% of acute coronary syndromes are caused by plaque rupture. And what that really represents is a lipid-rich plaque with lots of inflammatory cells, a thin fibrous cap, ultimately plaque rupturing, exposing those inner contents to flowing blood, resulting in thrombus formation, oftentimes with a lot of platelets and also with fibrin. So that's what causes acute coronary syndromes. And this next statement's a bit of an oversimplification, but when that's an occlusive thrombus, one often thinks of ST elevation MI, but it could be left circumflex that's occluded, presenting as a non-ST elevation MI. And the thrombus doesn't always have to be occlusive. Plaque erosion, it turns out, accounts for about 25% of acute coronary syndrome, so a bit higher than we used to think or say in the past, and might be better ways of characterizing what's going on. It might be a little bit of a shift in the epidemiology, a bit of both probably, and that is something that's a little bit more common in women than men to have plaque erosion. Can result in STEMI or NSTEMI, and here the underlying biology is somewhat similar, but it's more denuded endothelial surfaces that cause some perturbation of local blood flow and formation of thrombus. And here in particular, it tends to be very rich in platelets, more often presenting as an end STEMI than a STEMI, but again, either is possible. Then there's things like calcified nodules. Those account for about 5% of ACS and can present with STEMI or NSTEMI or unstable angina. And here, still there's lipid-rich plaque and inflammation, but there tends to be more calcium. There may be protruding nodules of calcium, some constrictive remodeling of the blood vessel, and oftentimes superimposed thrombus formation as well. So those are some of the more common causes of ACS, in particular plaque rupture and plaque erosion. Now, there are more rare causes of acute coronary syndromes as well. Coronary spasm is the cause of ACS in about 1 to 5% of patients. Depends which series you look at over time and geographically, but somewhere in that range. And it can consist of focal mood muscle spasm, but important to realize that it can occur with other types of presentations, not just ACS, can be multifocal or multivessel. And it's important to note that spasm and its probability of occurring increases when there's damaged endothelial cells. As it turns out, imaging studies have shown us through the years, most of the time when there's spasm, it isn't a totally normal vessel. Even if it appears that way on an angiogram, there's typically plaque in the arteries at the site of spasm. Spontaneous dissection or spontaneous coronary dissection, or SCAD, is another cause of acute coronary syndrome, and about 1 to 4% more common in women than in men, though it does occur in men as well. And it does occur in older people, not just younger people. I mean, for a board exam, the case scenario is typically a younger woman, maybe peripartum, but in real life, it can occur even in postmenopausal women and in men, though more frequently in women. And this typically occurs with an intimal tear, creation of a false lumen and a true lumen, and hematoma formation in the vessel wall, though there are many subtypes of SCAD. But in general, that's more or less what's happening. And then in maybe about 1 to 3% of cases, embolism can occur, such as when atrial fibrillation is present, or a thrombus in the left ventricle, or endocarditis, or that sort of thing. So a few of the different causes of acute coronary syndromes. Now, we've got lots of different ways of really nailing down what causes acute coronary syndromes when it's ambiguous. And I'm not saying that this needs to be done in every case for clinical care, but it certainly is illustrative for research purposes and sometimes useful in actual clinical care as well. And this is an example of plaque rupture as the underlying cause of a myocardial infarction in what otherwise looks like non-obstructive coronary artery disease. Maybe back, 30 years ago, we would have said, oh, normal coronary arteries. That phrase isn't so popular anymore, because even if the lumen looks okay on an invasive angiogram, it doesn't rule out plaque in the vessel wall. And even sometimes plaque that appears mild, as here in the distal right coronary artery, we can see with advanced imaging such as intravascular ultrasound or optical coherence tomography, OCT, that there's a lipid-rich atheromatous plaque here with a large necrotic core. And shown here, in fact, is a ruptured plaque with an empty cavity. So even though this looks like kind of mild disease, maybe a luminal irregularity, in fact, there's a lot of action going on there, biologically speaking, and in terms of ACS. So what we might have just dismissed and told a patient, get out of here, it's in your head, there's nothing wrong with you, or false positive biomarker, the troponins aren't accurate, it's just something else. No, in fact, this really was an ACS and the real thing, and likely the cause of the patient's symptoms. At a minimum, a marker for increased risk, because this patient has indeed had a myocardial infarction. So they're higher risk than they were yesterday when they didn't have a myocardial infarction. So that was plaque rupture. Here's an example of plaque erosion as a cause of myocardial infarction, again with non-obstructive coronary arteries, or MINOCA as it's sometimes abbreviated. And here you can see a lumen, which really doesn't look that obstructed, but on invasive imaging, we can see there's a calcified nodule that looks pretty big. Here is a luminal irregularity. Is it a big chunk of calcium? I think that's what I would have probably called it on fluoroscopy, although one can look on fluoro with and without contrast. Does it persist? I'm just showing you a still frame, but just with the still frame could be calcium, could be thrombus, could be something else. Hard to absolutely say, but it turns out actually this is an atheromatous plaque without apparent rupture, but a red thrombus that has formed on it. So this is likely plaque erosion. that has occurred here. So some insights given by invasive imaging and things like OCT or intravascular ultrasound or the combination catheters that are out there in development might provide insights. Once more, I'm not saying everyone needs this sort of invasive imaging, but in this particular case, it did help nail down the likely etiology. But it doesn't always have to be invasive. In fact, increasingly, it's non-invasively that we can figure out, did the patient really have a myocardial infarction? And imaging with things like MRI and CT can be extremely useful in delineating whether someone has a myocardial infarction. And shown here is a small, what appears to be septal myocardial infarction in someone whose invasive coronary angiogram was just read as normal. But, if we look here carefully at this non-invasive angiogram, there is, in fact, an occluded septal perforator. Very easy to miss on the typical quick invasive angiogram where the epicardial coronaries look to be okay and just think that, oh, all right, this person's troponin elevation and chest pain must have been due to something else or false positive. No, it turns out it really was a small but real myocardial infarction. All right, well, those are some of the more common causes of ACS. Here is a spontaneous coronary artery dissection, or SCAD, in the postpartum setting. This is a young woman in her 30s that came in with sort of classic chest pain a couple of months after delivery and had ST elevation anteriorly or anterolaterally. And as you can hopefully see, hopefully this all projects with the light, where the yellow arrows show is classic SCAD in a couple of different views. And then it turns out she was just treated medically with beta blockade and antiplatelet therapy. It's still a debate exactly what the cocktail of medical therapy should be, but that's often what's part of it. And then happened to have a coronary angiogram 6 months later that shows that the artery looks pretty good, at least angiographically appears to be well healed. So an example of spontaneous coronary artery dissection treated medically, as most of these should be in the absence of ongoing chest discomfort and dynamic ECG changes. This is another example of someone that actually came in with an ACS. Here's a coronary angiogram, left anterior descending artery in diastole, and then in systole, it's right here. Any of the fellows know what this is? Yeah, terrific. So it's a myocardial bridge. That's not typically thought of in the list of things that can cause an acute coronary syndrome, but every now and then it does and did, as in the case of this patient who showed up with the real ischemic sounding syndrome and biomarkers that were positive and ECG changes and that sort of thing. And, in the cath lab, we went ahead and measured the fractional flow reserve, as most of you likely know, a way of assessing whether a lesion is severe or not. And here it did look to be like it was less than 0.8, 0.76. So probably a severe lesion there. And oftentimes, this particular frame here was actually done with adenosine, but a lot of times when the concern is bridging, you might use something like dobutamine to augment myocardial contractility, and then that would likely cause an even larger drop than what I've shown here. This patient was treated with beta blockade and did fine. Very rare that one needs to stent or unroof these surgically. Every now and then that comes up, but pretty uncommon. All right, well, this is another example of a patient presenting with ACS. Young guy comes in and with a good story on telemetry. He's having all this non-sustained ventricular tachycardia, looks pretty ugly, negative tox screen. And here is his coronary angiogram. This is what is seen in the mid-LAD, looks to be a tight stenosis. You can't see it on the still frame, but a little bit of sluggish flow, certainly not TIMI3 flow. It's given some intracoronary nitroglycerin, and it looks a little bit better, but it looks still a bit narrowed. Here is the right coronary artery with what looks to be a moderate lesion. So, this is a classic example of any of the fellows want to say what you think this is. Yeah, it's coronary spasm or vasospasm, exactly. So the important thing to note here is even though it's really tight and gets better with nitro, there's still some underlying plaque here. And for that matter, in the right coronary artery, as is often the case, as is the case in the majority of instances of spasm where there's some plaque. Again, you may not see it on the invasive angiogram, but I can see it with non-invasive imaging, as shown in these images here. Using MR to look at the LAD, where we see moderate plaque in that same young gentleman and some moderate plaque in the right coronary artery. A case of plaque underlying severe coronary spasm. And he was treated medically with calcium channel blockers and nitrates and did well until he represented with ventricular fibrillation because he stopped taking his medicines because he felt so good. But then after that, he actually started taking his medicines and did fine. So those are some examples of common and rare causes of acute coronary syndromes. But for the majority of ACS, again, it's plaque rupture and plaque erosion. But you do want to have a full differential and really think about all those things in every patient that's presenting. So those other alternative diagnoses or rather causes of ACS aren't missed. But this is an algorithm in general for how I would recommend approaching ACS. It starts with the electrocardiogram, whether there is ST elevation or not ST elevation present, then treatment with antiplatelet and anticoagulant therapy, most often dual antiplatelet therapy, along with an intravenous anticoagulant. In the case of STEMI, catheterization within 2 hours, even if the patient needs to be transported. And if that's not possible because of a remote location or rural location or bad weather that grounds a helicopter, that sort of thing, there's still a role for fibrinolytic therapy, preferably alteplase or retiplase or tenecteplase, but in certain regions of the world, certainly not the US, then streptokinase is a possibility if cost is an extreme consideration. But even in those locales, there should still be transfer to a facility that does percutaneous coronary intervention within the next 24 hours. And in all cases, then coronary angiography should be performed. And if there is an obstruction present, well, in general, the STEMI patient should be treated with a stent. If it turns out that it's Minoca, well, then the patient should be treated with lifestyle modification and intensive medical therapy. Now, in the case of non-ST segment elevation ACS, that initial medical therapy is the same, and their troponins play a big role, ideally within the first 3 hours. If there's an elevated troponin, well, then an NSTEMI is diagnosed, and the algorithm is somewhat similar, although the timing is a bit different than STEMI. But in general, want to go to the cath lab in the next 24 to 48 hours, delineate the coronary anatomy, and then most of the time proceed with PCI, some of the time CABG, and the rest of the time medical therapy. Probably it's a split of 60 to 70% PCI, 10 to 15% CABG, with the remainder treated with initial medical therapy. That's what most registries in the US and worldwide show percentages around that. And if the troponin is not elevated, then unstable angina is diagnosed. It still exists. Some people have said, oh, is it disappearing with the high sensitivity troponins? No, there still is real unstable angina, even if you sort of factor out upcoding and things that I know do occur in our healthcare system. There are actual patients still we see with unstable angina. And if these folks have high-risk features such as heart failure on their exam, dynamic ECG changes, ongoing chest discomfort, or hemodynamic instability, they should be whisked to the cath lab and treated urgently, as would a STEMI or otherwise high-risk NSTEMI patient. But if they don't have these features, well, then medical therapy and risk factor control is reasonable. A non-invasive evaluation is reasonable. Historically, that's been stress testing. Increasingly, that's now been computed tomography, angiography, or CT angio. And if significantly abnormal results are present, well, then the patient should still end up going to the cath lab. But if not, if they've gone through that gauntlet and the test is low risk, well, then medical therapy and risk factor modification are the way to go. Some contemporary trials, just building upon what I've said, have been multi-stars AMI, showing that for MI patients, an approach of immediate, complete revascularization is superior to staged completed revascularization, built upon multiple trials that show that complete revascularization in the STEMI patient is the way to go. You know, this trial, if one interprets it very, very strictly, actually showed that absolutely immediate complete revascularization is indeed superior to stage. But, you know, most American interventionists haven't interpreted it quite that literally, and instead interpreted it as staged, meaning staged in the hospital or shortly thereafter. And I think, you know, despite the literal results of the trial, that's probably the right way to interpret it. That is, if you've got, you know, a prox LAD that's a culprit that you just fixed, and there's what appears to be an easy mid-RCA, you know, middle of the day, team's not exhausted, patient's quite stable, then it probably does make sense to just go take care of the right, you know, if the creatinine's 2, or it's a bifurcation lesion at midnight on Saturday, you know, there you might want to use some common sense and stage it for later on in the hospitalization or potentially after discharge, or in some patients, maybe just manage it medically, say an older, frail patient with really calcified coronary arteries and complex disease. So I don't need to interpret every trial absolutely literally, but this does lend more support here for the concept of as immediate complete revascularization as attainable. A FIRE trial similarly showing that complete revascularization is superior to culprit revascularization, extending that really to older patients, extending that even to some patients with NSTEMI. And interestingly here, even finding a lower rate of death from cardiovascular causes. Even death from all causes was lower. New England Journal doesn't allow anything other than the primary outcome to have p-values here, depending on exactly what the statistical analysis plan was pre-specified as. But you can see here, death is significantly lower. CV death is significantly lower. Of course, MI and the composite of death or MI are significantly lower. So altogether, it does seem to be a winning strategy, the idea of complete revascularization versus culprit only. Those lesions in the ACS patient in particular, we have more data for STEMI, but some data for NSTEMI. Those patients probably have vulnerable plaque all over the place. And even if something is a culprit lesion today, those other plaques can act up tomorrow. Then aggressive medical therapy does lower that risk, but probably nothing lowers that risk quite as quickly as a stent, assuming it can be done safely. Once more, you've got to use some common sense there. It doesn't necessarily mean that every patient with every lesion with ACS, especially in STEMI, should just be stented without thought. The ESC, neuropsychiatric cardiology, have, I think, nicely illustrated how ACS sort of evolved. So ACS patients are, of course, very high risk, but at a certain point, they kind of convert to chronic coronary syndrome. There certainly remain high-risk patients, but that trajectory of risk does alter, assuming that they've gotten things like revascularization and are on and adherent to, good medical therapy. But the point is they do still remain at elevated cardiovascular risk. So what can we do to address that part of the risk? That's an important aspect of caring for the patient with acute coronary syndrome. Well, this is where I'll pivot a bit from thinking about intervention to thinking about prevention. Prevention of the second event in ACS patients, but then ultimately prevention of that first ACS in the population. And these are data from Odyssey Outcomes. This is a trial of patients that had ACS more than a month ago, so not acute coronary syndromes, but relatively recent acute coronary syndromes in the prior few months. And these patients were treated with statins and had pretty good LDL control and other good medical therapy, but then randomized to a PCSK9 inhibitor, alirocumab in this case, versus placebo. And what was found was a significant reduction in cardiovascular events, about a 15% relative risk reduction in a composite of various ischemic events as shown here. And it's a number needed to treat of 49 for 4 years. So I would say, pretty good. Safe therapy other than injection site reactions, not much in the way of adverse effects that we're seeing. Not an enormous amount of uptake initially, despite the data here, probably because of the cost of the therapy and pre-authorizations and other barriers that were thrown up initially that have become much less now, but haven't disappeared. But nonetheless, that concept of lower LDL being important in the post-ACS patient was firmly established. There are more trials that are going on in this space. Evolve-MI is currently underway. The goal is to enroll about 4,000 patients that have come in with a STEMI or NSTEMI randomized to a PCSK9 inhibitor, evolocumab in this case, versus just routine care, to see if starting a PCSK9 inhibitor within the first 10 days or so of an ACS provides even greater benefit than what we saw in the Odyssey outcome trial, where, as I mentioned, everyone was at least a month out of their ACS. In fact, I wish the trial hadn't been done that way. There were a number of us on the executive committee that really, with Odyssey outcomes, wanted to start the PCSK9 inhibitor right in the hospital, thinking that'll improve adherence, both in the clinical trial, but then in real life, and maybe provide some incremental benefit in that really early post-ACS phase. But in that time frame, for a variety of reasons, the decision was ultimately made to wait a month till the patient was more stable. But hopefully with Evolve-MI, we'll fill in that gap and see whether early PCSK9 inhibition does influence outcomes, even if it doesn't really influence outcomes any more so than starting a bit later. I do think in real life, probably adherence would be better if a therapy is started in the hospital when the patient's thinking, oh, I just had a heart attack, and their family's focused on that. So probably some logistical advantages, but we'll see what the data actually show there. But this idea of the ACS patient and LDL control, I think, is important because these are more data from Odyssey outcomes in patients at least a month post ACS, where we see with lower LDL levels that there's actually lower rates of all-cause death. And this seems to be true within the range of patients with LDL that was studied in the trial, but going down to probably around this 20-ish to 30-ish range. And after that, there's just not enough statistical power to say, would this curve keep going down lower, because the way the trial was designed, once LDLs got really low by protocol, we backed off, or the investigators backed off. Again, that was part of a trial I didn't totally like. I would have preferred to just let the LDL go as low as possible and leave it there, both to look for safety and incremental efficacy. But anyway, what we can say from these data in the post-ACS patient is there does appear to be a benefit of getting the LDL down to that 20-ish to 30-ish range at least. And I think that makes sense because it goes along with what the LDL is when we're born. Newborns tend to have LDLs in that area. Well, this is changing, but sub-Saharan Africa historically has had LDL levels in that range with very low rates of atherosclerotic cardiovascular disease. Of course, with urbanization, things are changing around the world, but there's good epidemiologic data to support that's a normal, natural LDL level for humans. If babies are able to form brain tissue and grow with LDLs in that range, probably it's okay for an older adult with cardiovascular disease to have LDLs at that level, even if it's sustained for years and achieved pharmacologically as opposed to just genetics. But at any rate, in terms of what we're doing in the US, this is some recent data from NHANES. We're not doing that well. You can see here that 3 out of 4 in red patients in the US with coronary artery disease, I'm not even just saying ACS, this is a whole universe of coronary artery disease, have suboptimal LDL control, not meeting the ACC/AHA targets. And if we use the European Society of Cardiology guidelines, which I prefer for this purpose of less than 55 milligrams per deciliter, 9 out of 10 patients are not meeting those guidelines. So that's actually pretty bad. And you might say, oh, well, that's because PCSK9 inhibitors are expensive, can't afford them. Those are potentially valid points, but the use of ezetimibe, which is generic, which also has good data, it's about 6 or 7% in this cohort. So yeah, maybe there are issues with cost for some of the therapies I'll be discussing, but even when it comes to things like generic statins and ezetimibe, there's a lot of underutilization. And okay, you could say statins, well, there's a lot of bad press they get. There was some recent bad press as well, where it's just the press and the internet and all sorts of folks go off on statins and people that support their use. I think you guys post this on YouTube, so probably someone will make some silly comments about what I'm saying, supporting the use of statins in appropriate patients. But ezetimibe, that's really peculiar that it's underutilized because it shouldn't really cause much in the way of side effects. It acts locally in the gut, so other than maybe the occasional GI distress, really there shouldn't be much in the way of side effects. So that is hard to just sort of blame the internet or the system or folks. I mean, that's really doctors that are not prescribing it appropriately. So this concept of risk related to LDL, I think, is best encapsulated by a concept known as cholesterol years. You're all familiar with pack years of tobacco exposure. Everybody knows that. More pack years, higher risk of cardiovascular disease and cancer and lung cancer and other things. But this is a concept that's related of cholesterol years. So this is looking at patients from birth and just seeing how high is the cholesterol, how long has it been elevated, and essentially looking at the area under the curve. So if somebody has bad genetics and has high LDL cholesterol from birth, such as a heterozygote for familial hypercholesterolemia, that person's at really high risk. Whereas, if they have good genetics, but they are living a long time and maybe their lifestyle isn't so great, well, then they're also at risk. So it's really a matter of looking not just at the genetics, not just at the lifestyle, but the cumulative burden of LDL through one's lifetime. and trying to figure out where in that cascade to actually intervene. And it really depends on how high their risk is and the cumulative exposure at that point in their life where you're meeting them is. And there's a lot of trials that are ongoing for secondary prevention right now with LDL lowering strategies, but I'm going to focus now on primary prevention, that is trying to prevent the first event, as is the case with Victorian 1 Prevent. So this is a trial that launched just about a year ago, where we're looking at PCSK9 inhibition, in particular inclisiran and siRNA given every 6 months, to see if that approach can work in a primary prevention setting. And these are folks that are at elevated risk, but in the primary prevention universe, and are randomized to either inclisiran or placebo. And the goal of the trial is to see if there is or isn't any impact on MACE, major adverse cardiovascular events. So if the trial is positive, it'll really change our approach to primary prevention, where it's not just a matter of, try to take your generic statin and maybe ezetimibe, but really ratcheting up a level to say, no, we need to get out the big guns and blast your LDL and get it really low. And if the trial is negative, then it means probably in patients that are walking around feeling okay, we don't really need to go nuts in terms of getting their LDL super low. So I think it'll be informative either way. Beyond the LDL axis, though, there is more in terms of cardiovascular risk, and inflammation is a big part of that. And this is from a recent analysis that Paul Ritker led, where we combined data from 3 contemporary trials. This was prominent that Dr. Ritker and Pradhan led, REDUCE-IT, which I was involved with, and STRENGTH, which Dr. Nissen and Linkoff and folks at Cleveland Clinic led. And what we see here, pulling all these data, is the powerful role of inflammation. In patients, you can see in various quartiles the risk of cardiovascular death, where in this relatively well-treated population with well-controlled LDL, so this isn't the full universe of LDL, these were patients that had pretty good LDL control even by contemporary standards. Well, the LDL doesn't seem to be contributing that much to cardiovascular risk when compared to the hsCRP. Again, the LDL in this highest quartile is increasing risk, but look at how much more the high sensitivity CRP as a surrogate of arterial inflammation is contributing to the residual risk. So probably a lot more we can do targeting inflammation, perhaps more than even further targeting LDL, though ongoing trials will hopefully nail that down, such as the ongoing Artemis trial, which was launched relatively recently. And this is a patient trial of ACS, about 10,000 patients or so with STEMI and STEMI, randomized to an IL-6 inhibitor or to placebo. So this trial is also powered to look at major adverse cardiovascular events, the usual sorts of culprits. And this will provide, I think, good evidence, hopefully definitive evidence, one way or another, whether targeting inflammation in the post-ACS patient is indeed a valid and safe way to target some component of residual cardiovascular risk. Here's yet another pathway towards cardiovascular risk reduction. These are data from the REDUCE-IT trial looking at a triglyceride-lowering drug, icosapent, though probably its major mechanism of action is through other pathways than triglyceride reduction per se. But we see here a significant reduction with icosapent in major adverse cardiovascular events, including heart events like CV, death, MI, stroke, in the overall hybrid secondary primary prevention population studied, with real amplification of benefit seen in that subgroup with a history of prior ACS or myocardial infarction. This is actually myocardial infarction. The ACS data just got published in EHJ today. But when we're looking specifically at STEMI and STEMI patients prior MI, we can see here a significant reduction in the time to first event, in total events, which includes first and recurrent events, true for overall MACE and true for heart events like CV, death, MI, stroke as well. So large relative, large absolute risk reductions in starting this form of therapy in patients with a history of MI. This isn't right at the acute setting, though one might imagine if it were started closer to the ACS, there would be even larger benefit. And the benefits extend to cardiovascular death as well. This was significantly reduced in the overall trial, but here in the subgroup of patients with prior MI, we also see a significant reduction, but larger in absolute terms than seen in the overall trial. So even the hardest of endpoints influenced with this therapy in patients who are otherwise treated well with statins. Actually, one of my Brigham fellows is going to present the LDL data from Reduce It at ACC in another week. So let me move now to yet another way of reducing residual cardiovascular risk, and that's the concept of SGLT2 inhibition that has really taken hold in heart failure, appropriately so based on the data. And there are a bunch of trials I'm not going to review for the sake of time that have established SGLT2 inhibitors as a core therapy, both for heart failure with reduced, but also heart failure with preserved ejection fraction in the acute setting, as well as in the chronic setting. What I want to focus on is SGLT2 inhibition for that purpose, but maybe even SGLT1/2 inhibition, if you're not familiar with that concept. SGLT2 is expressed in the kidneys, as you all likely know. SGLT1 is also expressed in the kidneys, but also expressed in the gut. It slows down glucose absorption as it's going through the digestive system, and in that way does help with glycemic control. It's also expressed in the myocardium and brain, and there's ongoing research to see if that actually matters clinically. But in the SCORE trial, for example, we saw a significant reduction in heart failure with SGLT2 inhibition, although here specifically is an SGLT1/2 inhibitor, sotagliflozin, though the benefits really, I think, are a class effect for SGLT2 inhibitors in reducing heart failure events. So I show you this not to just point out the heart failure, which is well known, but also what we noted in SCORE, which may not have been as well appreciated, though it's there in the New England Journal paper and supplement, is that there was a reduction in ischemic events as well. So that hasn't been as clearly seen with the SGLT2 inhibitor. So maybe this reduction in both MI and stroke and the composite is due to the incremental contribution of SGLT1 over SGLT2. There's some Mendelian randomization data that supports that SGLT1 may in fact have an important role in cardiovascular disease beyond just the SGLT2. So this is a finding that I think is of potential importance. Is it really specific, though, to sotagliflozin, and is it SGLT1, or did we just happen to get the right patients in SCORE? Patients with diabetes, chronic kidney disease, and cardiovascular risk factors, a pretty high risk population, albeit an outpatient population. Well, it could be the drug, it could be the exact patient population, but some trials should answer this question, at least indirectly. I mean, only a head-to-head trial of say, DAPA and EMPA versus SOTA would really answer it, but at least to do the thought experiment, DAPA and MI and MPACT MI, we're looking at dapagliflozin and empagliflozin, respectively, in ACS patients. So one might think that if SGLT2 inhibitors reduce ischemic outcomes, well, if we saw a reduction in ischemic outcomes in stable, albeit high-risk cardiovascular patients, it should be even more evident that there would be a reduction in ischemic events in post-ACS patients. And DAPA-MI, as you know, it was published in NEJM Evidence recently. There was no significant reduction in ischemic events. There were some significant reduction or improvements in things like glycemic control, but in terms of sort of heart events, there was no significant difference. So at least with DAPA-MI, dapagliflozin, in a patient population where I was thinking and hoping there would be a reduction in ischemic events if it was a class effect, well, there wasn't any. And MPACT-MI, well, you have to go to the ACC to see what the MPACT-MI shows, but we'll see whether empagliflozin in a similar context as DAPA-MI, the post-ACS patients, does or does not reduce ischemic events. If it does, then I'll say, well, I guess there probably is just differences between these trials and it's a class effect. And if it doesn't, then I might say, okay, there is actually something special about the SGLT1 added to SGLT2 inhibition. I do think these drugs that were initially studied for diabetes, such as the SGLT2 or SGLT1/2 inhibitors and the GLP-1 agonists, really are cardiovascular drugs and going to change the cardiovascular landscape. These are some data pertaining to semaglutide, and I think apply to some, but not all of the GLP-1 agonists. Here, we're not talking always about class effects, unlike with SGLT2 inhibitors and heart failure and kidney outcomes. Here, some of the GLP-1 agonists seem to work for more than glycemic controls, others don't. But semaglutide definitely is one of the ones that works. And these are some data from SUSTAIN-6 and PIONEER-6 showing the benefit on MACE irrespective of the baseline hemoglobin A1C. You can see pretty flat hazard ratio showing consistent benefit. At the extremes, there aren't many patients. So that's why the curves kind of are all over the place. But in this range here, where there's a fair number of patients and statistical power, even in the lower ranges of hemoglobin A1C, significant reductions in MACE. So there's something that GLP-1 agonists are doing, or at least some of them, that goes beyond, I think, just glycemic control. And from the same analysis, it seems to be true for cardiovascular death, MI, and stroke, where all components of that composite are improved across the glycemic range, albeit with less statistical power here than the prior slide. All right, well, for the final part, let me just talk a little bit about guidelines. Have to at least mention guidelines in giving a talk on ACS, and I'll focus on the chest pain guidelines because I think these are really good guidelines. And if you haven't seen them, I'd say take a look at them. They're color-coded. There's nice tables and figures. Even if you don't want to read all the text, just quickly go through the figures and tables. And each letter here stands for something important. Once more, for the sake of time, I'm not going to read through all this, but things like C stand for chest pain means more than pain in the chest, to think about other symptoms that patients with ACS can present with. H means wherever you are in the world, really ought to be using a high sensitivity troponin at this point in time, and so forth. Each of these has some deeper meaning. But to summarize the highlights of this particular guideline, it's the first US or international guideline for evaluating chest pain. The idea being that it is patient-centric, so it's not a guideline about STEMI, or it's not a guideline about stenting or bypass surgery or some imaging test. It's focused on how the patient presents with chest pain. They don't know what test or procedure they need. So it's focused in a very patient-centric way. It's focused on both acute but also stable chest pain. It emphasizes deferral of testing in low-risk individuals. So don't just test just for the sake of testing, or just for medical legal concerns. It really, if the patient's low risk, the guidelines are saying, leave that patient alone, at least for the time being, in terms of testing. Doesn't mean you shouldn't keep an eye on them in the future. Doesn't mean you shouldn't treat them for risk factors. There are contemporary models to estimate the pre-test probability of CAD. That's always important. Emphasis on more selective use of imaging, evidence-based recommendations with increased quantity and quality versus prior guidelines, an emphasis on intensification of preventive therapy. So even though it's a chest pain guideline, an important part that's interwoven to those guidelines is a focus on trying to prevent ischemic complications, regardless of whether that chest pain is deemed as being due to coronary artery disease or not. And importantly, it incorporates the use of contemporary imaging techniques like CT angio. And not everybody was happy about that, but we're going with what the data and randomized clinical trials support. And here is a pyramid of testing that's in the guidelines, basically saying for asymptomatic folks, in general, no testing is required. Got to say, moving from Boston to New York, it seems New York's a bit more aggressive in terms of testing folks with asymptomatic status. And there is a lot of patient demand, a lot of worried folks out there, and a lot of imaging techniques that are out there to help gauge risk. But we really need more evidence before just randomly testing asymptomatic folks. There's a lot of cost and potentially some risk, which is downstream testing and procedures in particular. Low risk also in general, no testing, but every now and then it might be reasonable to at least get an ECG or coronary calcium scoring and scan. Intermediate risk there, probably do want to get either anatomic or functional testing. By that, I mean a CT angio or a stress test. And then for high risk in general there, you do want to go to the cath lab, and certainly for confirmed ACS in the absence of contraindications, those are all patients that still, for the most part, should be treated with invasive coronary angiography, and based on that, if appropriate, percutaneous or surgical revascularization. We also address in the guidelines symptoms and signs. That's not necessarily what gets people excited during a talk, but there's actually a lot to learn, I think, about signs and symptoms. I mean, that's what makes ACS in the emergency department, or even just triaging chest pain in the office, so challenging. I mean, is it really coronary artery disease? Is it really ACS? Very difficult to just tell from a history and physical without further testing. But even for something as simple as eliciting symptoms, there's work going on. This is from the Hermes study using cardiolinguistics and artificial intelligence to reframe typical and atypical angina. And actually, this version of the guidelines say not to use the word atypical anymore, but rather non-cardiac chest pain, because it's believed that the atypical nomenclature really is a way of doctors coding to one another, this is bogus chest pain, get them out of here. And instead of just minimizing patient symptoms, instead trying to focus, well, what is causing their chest discomfort or potentially a serious syndrome, even if it isn't coronary or cardiac. But at any rate, what this study has done is look at patients, and in this particular analysis, the data are broken down by males and females. And these are folks that are coming in with a suspicion of coronary artery disease that have ended up in a cath lab. So that filter has already occurred. They're in the cath lab. That decision, whether you agree with it or not, has been made. But then what happens is they are interviewed by physicians and fellows and physicians' assistants and a variety of different folks. And those with consent of the patient and the practitioner, those transcripts are recorded and then transcribed and then analyzed using machine learning techniques, and symptoms are clustered. So there's some pretty sophisticated AI going on, but what the results show, the bottom line, so to speak, is that the majority of male and female patients were presenting with chest discomfort. Of the ones that ultimately, since they were in the cath lab, were shown on invasive coronary angiogram to have obstructive coronary artery disease. So probably all true, and related in that case. So even though there's a lot of talk about atypical symptoms or non-cardiac symptoms, in fact, the majority of people with real obstructive coronary artery disease that ended up in the cath lab were having chest discomfort. Now, that doesn't mean there weren't other associated symptoms. A large majority of women, but also men, were having associated non-chest area symptoms. So even though what is often taught is, oh yeah, women have lots of atypical symptoms, men don't. In fact, both men and women are having a lot of atypical symptoms, if you want to use that terminology. But the majority are having chest pain, including women. Now, there were some subtle differences here in terms of how the data were sort of elicited, recorded. That is, it did turn out that women reported more symptoms than men. They didn't always necessarily lead with saying, there's an elephant sitting on my chest. They may have led with, I'm having fatigue and shortness of breath. But if you actually listen to them carefully as a human, or listen to them objectively as a machine learning algorithm, maybe at the end of that sentence, say, oh yeah, there's some chest pain here too. So there were subtle differences in the way that the healthcare practitioners may have heard the information from male and female patients, but the information was all there. And even though there's been a lot written about AI and how it could potentially increase bias, in this particular application and circumstance, maybe it would have been useful to decrease preconceived notions that physicians and PAs and so forth have. And I think a lot of these technologies, not just artificial intelligence, but computational simulations, extended reality, are in fact going to change cardiovascular medicine, certainly in the lifetime of the people sitting in the front two rows, but I would say really for all of us in this room. And here's some examples of extended reality and its application in the interventional lab, but this applies to other areas of cardiology as well. Here's a fly-through computational simulation of a coronary artery bifurcation, some computational fluid dynamics after coronary stenting. This is a real-time intraprocedural visualization of a bicaval bidirectional Glenn shunt, so complex congenital heart disease, but a way that intraprocedural visualization can help the cause. And this is some real-time interaction of an operator with angiography in a virtual cardiac cath lab. So all different things, in some cases experimental, in some cases actual patients right now in real life that are benefiting from these approaches. A couple of other things here before I wrap up. AI is also working its way into actual imaging tests that we're using in clinical practice and for research today. These are data from Evaporate FFR CT. This was the first demonstration, actually, of a drug effect on fractional flow reserve as determined by a CT angio. And this is data where patients were randomized to icosapent ethyl or placebo in a small mechanistic study, but showing, as I said, for the first time, an effect on FFR, determined non-invasively of a drug. So hopefully in the future, there can be larger studies looking at a variety of different medical therapies, maybe novel medical therapies, maybe in phase 2 testing before a large, expensive phase 3 trial to see if medications might affect the flow of blood in the coronary arteries and potentially affect things like angina and ischemic endpoints. This is another example of another AI-enabled CT angio platform. Here, looking at coronary arteries and looking at the degree of stenosis, plaque burden across multiple segments of multiple arteries, looking at plaque morphology, hence the color coding, and trying to integrate all of this along with whether there is or isn't ischemia in the vessel to gauge patient risk. Patients love this, of course. Doctors often love it too. I think it can be useful to convince someone that has plaque that, well, they really do need to modify their lifestyle, and maybe taking the statin is a good idea. So I think it can be useful in that way. But, which patient should really be getting this? And is this potentially a genie out of the bottle where it just leads to a bunch of testing and downstream testing and just escalates healthcare costs without actually improving healthcare outcomes? Well, that's really the million-dollar question, I think, and something that we hope to help to answer in the Transform trial, which was just launched last month, as a matter of fact. I'm happy to co-chair this with David Marin, who, as you may know, is the head of preventive cardiology at Stanford. And what we are hoping to do is enroll about 7,500 patients or so, primary prevention, but higher risk folks with diabetes or prediabetes or metabolic syndrome, but not symptomatic patients. So asymptomatic, I guess I'd say higher risk primary prevention patients, and then randomize them to usual guideline-based care or a personalized strategy of intense lifestyle modification, in particular intense medical therapy. Everybody is going to get a coronary CT angio. In this arm, the coronary CT angio will be blinded. I mean, if they have like tight left main or something, that's a bit different. But in general, everyone's blinded until the end of the study. In this arm, well, it's known what the CT angio shows, both the doctor and patient. And based on that information, their medical therapy will be titrated depending on the stage of plaque they have. So if it's stage 0, they don't have any plaque, well, no need to really throw the kitchen sink at them in terms of medical therapy. If they have stage 3 plaque, well, then that's the time to get really aggressive. There's a repeat CT angio at 2 years in both arms, blinded in this arm, not blinded in this arm. And if there seems to be progression of disease despite that initial battery of medical therapy, then it's ramped up to the next level. So this trial is designed to evaluate if there is an effect on major adverse cardiovascular events. And if there is, then I think we would have completely changed the paradigm for primary prevention. And CT angio would be the colonoscopy of cardiovascular medicine, just like everyone over 50 should get a colonoscopy. To screen for colon cancer, it would be a similar sort of thing here. And if the trial is negative, it means we should just stop doing random CT angios just because patients want them or doctors want to do them. So I think either way, it would be informative. And this US-based trial just started. And that's Transform Outcomes, but there's 2 other trials interwoven here, Transform Plaque, to see if this strategy reduces plaque progression, and Transform Classify to see whether a picture is worth more than 1,000 words. That is a CT angio and staging of plaque more precise than just the, say, ACCH, a risk calculator, or the many other risk calculators that are out there. So 3 different hypotheses and trials nested into one. And the idea really is to go after residual cardiovascular risk in the control arm. Everybody's going to get guideline concordant care in terms of LDL control and that sort of thing. But in the investigational arm, we're really going to throw the kitchen sink at them in terms of getting the LDL really low beyond what guidelines recommend for that population, with things like bempedoic acid, PCSK9 inhibition, colchicine in patients with elevated hsCRP, ramping up the antithrombotic therapy, using icosapent ethyl, not just for places where it's indicated, such as elevated triglycerides, but even going beyond what just the label endorses. We don't have Lp(a) lowering therapy because there's no specific approved therapy, but if Lp(a) reducing trials are positive and report out during our trial, well, then we will, and approved and available, then we'll add on Lp(a) lowering strategies as well. And for those with diabetes, there'll be aggressive use of SGLT2 inhibitors and also GLP-1 agonist, and maybe some of the novel agents like the dual incretins as well. So I've gone through what I hope was a useful perspective on identifying the highest risk patients at the apex of this risk pyramid, those patients with ACS, tertiary and secondary prevention, trying to reduce the large residual risk in those patients but then trying to move even lower down in the pyramid, targeting primary prevention and targeting risk factors to hopefully prevent the development of cardiovascular disease in the first place. Doesn't mean that this bottom part of the pyramid isn't important. Certainly from a public health perspective, nothing beats primordial prevention, that is healthy diet and lifestyle, to try to prevent the development of risk factors in the first place. Well, thank you very much for your attention. Really great to have the opportunity to come speak to you. I'm happy to take any questions here or through Zoom.
Thank you, Deepak. Just on behalf of the faculty and the fellows, this was one of the best lectures we have heard. We cover everything from prevention, primary prevention, secondary prevention, and acute coronary syndrome. Many questions that we could ask you, but I want to ask you one related to disparities, right? Many of the therapies that you mentioned here are difficult to implement in our environment here. In fact, Leandro and his team has been trying to convince many members of our faculty post-MI to use PCSK9 inhibitors, and it's been a lot of resistance, you know, from the paperwork to the challenges with the insurance company. But the question that I wanted to ask you is actually different. It's about thrombolytic therapy, which you touch in one slide, but you comment more. I mean, we think about thrombolytic therapy as something that we use in the rural environments, but many of our patients here actually drive directly to an emergency room where they get chest pain in the setting of acute coronary syndrome, and they end up going to a hospital that does not perform PCI. We have great door-to-balloon times, but we have very poor pain to balloon times in our environment. And the question is, should we reconsider the strategy of thrombolytic therapies in New York City?
You know, those are really both great questions. Even though you were focused on the second, the first one's really important, so I can't let it go unanswered. I think disparities are really important. You know, those of us practicing in New York City are particularly attuned to that, I think. And here, especially, you know, in the Bronx, you're doing just an incredible job taking care of patients that are indigent. And you know, I'm really happy, by the way, that you got the $1 billion for your medical school. Really well deserved, and I think that's going to transform care, not just in the Bronx, but throughout the region and eventually the world. So really, congratulations on that. You know, it's tough tackling disparities because it's a problem that goes beyond just an individual physician. It's a healthcare system, and even beyond that, a political and economic issue. But I think there are things we can do. That's why I showed that NHANES data, right? I wasn't just talking about underuse of things like PCSK9 inhibitors. They are underused, but I mean, we saw a single-digit use of, you know, ezetimibe. So there you can't really just blame the system, or drugs are too expensive, or, oh, this talk just talked about expensive drugs. I mean, okay, if you believe all that, why is every cardiologist not, or primary care physician, not using ezetimibe in every patient who's eligible, right? So actually, we do a bad job as a healthcare system, and some of that is patient non-adherence, even for inexpensive therapy. Some of that is, you know, inertia on the part of physicians, and some of it's just the healthcare system, you know, things like pre-auths for expensive drugs. But again, for ezetimibe, that's not the case. So I think we can do better with what we have. A lot of what I mentioned, SGLT2 inhibitors, there'll be generic ones in a couple of years, GLP-1 agonists as well, you know, going generic soon. So, you know, there's very little of what I mentioned that isn't either achievable with generic meds or soon would not be. But, you know, it's interesting. Nitish Chaudhary at the Brigham did a great study of post-MI patients where free medicines were provided, and it improved adherence statistically significantly. But the absolute increase was actually rather small. So we're always thinking of cost as a barrier. But even in that trial of post-MI patients getting free medicines, adherence was still pretty bad. Generic statins in the registries a year after MI, 50% are off them. Can't blame cost there. So it's a complex issue. Cost is part of it, but adherence is multifactorial, and there are other things that come into play. Your second question, should lytics come back? I mean, in New York City, it's hard to make an argument to use them, is my honest answer. I mean, again, you know, if there's a blizzard or a flood and you know can't get a patient in the cath lab, then go ahead and give lysis. For folks 75 or older, I would use the STREAM algorithm of half-dose contemporary lytic, like a half dose of tenecteplase or something like that, and then still transfer them once the flood clears or the helicopter can fly or whatever. But in general, in urban U.S. areas, it's hard to really endorse the use of lytics anymore. I mean, there are enough there's an oversupply of cath labs actually in New York City, so it's really hard to make that. But do we need to do a better job with our delivery of emergency services? I think so. I mean, I'm kind of surprised this isn't so much the case, I think, even in Boston, which gets blamed for bad drives, but in New York, I've been surprised how many times there's an ambulance and people just don't move over to the side. I mean, I was always raised, you have to do that when the ambulance is there, but I don't see, I see the opposite. Sometimes I see the ambulance going and people jump in behind it so that they can speed, which I guess is a clever thing to do, but I've just been sort of dismayed that so many people don't, stop for the ambulance. It's really a weird thing.
Thank you. That was a wonderful lecture. It was amazing the perspective from prevention to prevention. It was very unique. And just going back to what Marvin was usually talking about, if you have a protocol here trying to use guideline directed PCS inhibitors next to get after MI, but we've seen a lot of resistance, and we've seen also not just here, but other places, people in PCI, we are injecting LDL, and then persistently use with people with persistent LDL from the 100s up to multiple stents. So can we bring back LDL as a quality measure? Do you think that's a way to tackle this, or how can we go on?
It's a great question. I mean, I thought LDL was a quality measure unless things changed in the past year or so when I was moving, because I know in the Brigham Cath Lab, we were definitely tracking the use of statins or some LDL therapy or a listed contraindication in our post-PCI patients. And we made sure that number was 100%. That is the sum of statin or statin intolerance and documented as such was 100% or 99% or something. So I actually think it is currently a quality measure, but if for some reason it got retired, then I'd say bring it back. I mean, I think, that is really important. I think quality measures, as long as they're not associated with sort of punitive actions towards the physician, I think are really useful. When they're coupled with punitive actions, I think it backfires, it leads to gaming the system, it leads to sort of lack of morale among healthcare workers and so forth. But I think when it's not coupled with just sort of a stick and a punitive measure, I think quality improvement projects are really important, and measuring things like documentation of LDL and action based on that really important. But with the PCSK9 inhibitors, like Dr. Garcia said, I mean, there are issues with the pre-authorization still. They're better. Part of the problem was that physicians were soured with the initial launch, right? The drugs were priced way too high. I mean, I actually led the Odyssey Outcomes cost-effective analysis, and that analysis, in which I worked with physicians and scientists and healthcare economists from the two companies that sponsored the trial, that analysis that we jointly did found that the drug was priced too high. So their own internal, sort of physicians and scientists said, yeah, the drug is priced high. So, I think it would have made sense to use the cost effectiveness data and price the drug appropriately, as opposed to just sort of launching at a really high perceived price, and then third-party payers like, that's too expensive, and then physicians also think it's too expensive. So the launches were sort of unfortunate and led to a lot of hesitation that has persisted, even though the prices of both the monoclonals have come down, for example, even though the pre-authorizations can still be painful, but aren't quite as painful as they used to be. But yeah, physicians, once they form an impression, a lot of times it doesn't change. But hopefully the new round of data will help the cause as well. Some were a little underimpressed with the absolute risk reduction seen in Odyssey Outcomes or Fourier, which was the evolocumab trial. But that's because the trials were too short duration. Each trial needed to be longer. In fact, the executive committee of each trial, the academic executive committee of each trial said, these trials need to be longer to see the full benefit of LDL. But there's always a complex relationship between the science, but the business too, where there was a business case on the part of the companies to get the drugs out to the market as soon as possible, as opposed to just being stuck in a trial for too long. So a lot of competing sort of things, but yeah, hopefully this new round of data will help the cause.
There's a question from Mark Manigus at Weiler Hospital, who's one of our director of the cath lab there. And it's related to CRP. You worked with Paul Richter for many years, and probably still do. So CRP can be elevated in many clinical, subclinical inflammatory conditions other than atherosclerosis. So how can you tease that out in trials? And I would extend that in clinical practice.
Oh, yeah, it's a great question. I mean, if you're doing hsCRP in an outpatient for cardiovascular risk assessment, it should be in an outpatient that doesn't have, an obvious infection, doesn't have a cold, nothing else going on. But then I think it's pretty useful in the clinical trials in that stable situation where patients, for the most part, with inflammatory conditions are excluded and active infection excluded. Multiple trials and registries have shown that it predicts cardiovascular risk, even in the ACS setting where a big MI is going to raise the hsCRP, just like, in the old days, we look at the white blood cell count and then a big STEMI would raise the white blood cell count. Even in that setting, it is predictive because some people will have an elevation and some people have a really high elevation. So it does even there help. But in general, the way to use it would be in a stable outpatient setting where it does seem to provide incremental risk prediction. But you have to use it in the right context. I mean, if someone's coming in with a Crohn's disease flare or rheumatoid arthritis flare, well, those people are at elevated cardiovascular risk too. So it's complex to even just say, don't measure it then. You just have to interpret it differently. But in general, it's meant for folks in stable, non-inflammatory mode.
The amazing lecture is of course response to all the stages of atherosclerosis. I guess my question is, I consider myself like an early adopter of the evidence. And I really enjoy when I'm able to kind of get optimal control of different pathways, inflammatory, thrombotic, lipid, and so forth. But sometimes we feel this little kind of uneasy feeling. We have these patients have multiple medications. It's like 5, 6 plus the other one. So I guess the question is a polypill some sort of like a package, a solution? Do you see that in the future? Already efforts in trying to kind of simplify this?
Well, I think it's a great question. I didn't show the slides for the sake of time, but the SECURE trial in New England Journal of Medicine that Dr. Fuster chaired, I think showed pretty conclusive evidence that in the secondary prevention setting, those were actually post-MI patients, that the polypill reduces ischemic events. If you look at the tables in NEJM, actually cardiovascular death was also significantly lower, the 95% confidence interval in cross unity. So it reduces ischemic endpoints, including CV death. And it seemed like what mediated that reduction was better adherence to the therapy. So, I think that the polypill, if we had one that was approved and, regulated and so forth, and say, I think it would be a great approach. You do have to know your patient though, because there is a risk also of complete non-adherence, right? If the patient says, I'm not going to take the polypill, well, then they're taking nothing, or if they're on a polypill and they're having gingival bleeding, they're like, oh, I'm bleeding. This is horrible. This could be dangerous. I'm going to stop this medicine. Well, they're stopping not just the aspirin, but possibly also the statin. So you do need to, we still have an important role, physicians and nurses, in educating the patient about the drug, why they should take it, and potential side effects, and what are bad side effects, and what are ones like gingival bleeding that can, probably be managed. So adherence is a complex sort of issue, but I do think polypill is part of a strategy that can help. But we would need an approved one, before it's actionable in the US.
Well, thank you again very much for joining us today. I think you have a meeting with the fellows.
Oh, I think so. I look forward to that. That'll be fun. Great. Well, thank you once again for your attention. It's a privilege to be here. Oh, thank you.
You guys want to stay here and we go to your room?
Since I didn't go to the dinner yesterday,
Great to see you. It's been a long time.
long time.
Let me get out of Zoom here.
The first time I met him was at the clinic, but